Coming to prolapse, what is the meaning of prolapse? Herniation of content from its normal anatomical position is called as prolapse. There again, as we are discussing about the uterus, there is uterocervical prolapse and vaginal prolapse. Coming to uterocervical prolapse, there is Shaw classification where there is normal, first degree, second degree, third degree, and precedentia. The first degree is where the descent of the cervix into vagina, descent of cervix into introitus, and descent of cervix. Third degree is descent of cervix outside the introitus, and precedentia is all of the uterus outside the introitus. And POPQ classification is where pelvic organ prolapse quantification classification, and the reference point here is hymenated remnants, and the Baden-Walker classification also reference point is hymen. And coming to basic anatomy, the mechanical support. Talking about mechanical support to the uterus, see the angle of anteversion. This is 90 and the angle of anteflexion is 120. The first step in prolapse is retroversion of the uterus. It goes behind. And the ligaments supporting the uterus are mainly their primary support and secondary support. The primary supports, we have the pubocervical ligament, and we have the transverse bicardinal or McIntosh ligament, and we also have uterosacral ligament. And the secondary support is mainly the round ligament of the uterus. And muscles supporting the uterus are mainly the levator ani muscles. The levator ani consists of pubococcygeus, iliococcygeus, and ischio-coccygeus, but ischio-coccygeus is not. But ischio-coccygeus does not help in supporting the uterus. And muscles which do not support the uterus here are ischio-cavernous muscle and ischio-coccygeus muscles. And the most important support of uterus is levator ani. In that too, the main is pubococcygeus, this one. And other muscles are superficial transverse perineum muscles, deep transverse, and ischio-cavernosus, perineal membrane muscles, superficial perineum muscles, and bulbospongiosus muscles, and external urinary sphincters. Coming to vaginal prolapse, there is anterior vaginal wall prolapse and posterior vaginal wall prolapse. Coming to anterior vaginal wall prolapse, it is called a cystocele whenever there is upper 2/3 of the anterior vaginal wall is prolapsed, and urethrocoele when the lower 1/3. And the similar one where there is extra additional of middle 1/3. So upper 1/3 posterior prolapse is called enterocoele, middle 1/3 rectocoele, and posterior 1/3 laxed perineum. Differentiating between an enterocoele and a rectocoele. Clinically, by perrectal examination, is a bulge felt on tip of the finger. This is called enterocoele. Where a bulge is felt on pulp of the finger, it is called as rectocoele. And also in trans-elimination test, it becomes trans-elimination is positive for enterocoele and negative for rectocoele. And Delancey's level of supports, where this is the bladder, this is the vagina, this is the pouch of Douglas, and this is the rectum. It is divided into 3 levels, level 1, level 2, and level 3. And the level 1 supporting structures are nothing but the uterosacral ligament and cardinal ligament or McIntosh ligament or transverse ligament. And whenever there is defect in this, it leads to enterocoele. And the second level, coming to the second level, the structures supporting are arcus tendinous fascia, and if at all there is any defect, it leads to cystocele. And coming to the third, if there is any defect in the ligament supporting this level, there is occurrence of urethrocoele. Defects lead to urethrocoele if there is an anterior defect and laxed perineum, and posterior defect. Structures supporting here are perineal body. What are the characteristics of prolapse? So it occurs when the muscles or ligaments becomes weak, right? So the characteristics are it is seen in elderly, repeated childbirth, that is multiparous, especially with obstructed labor, prolonged or perineal tear, or instrumental delivery. Other risk factors are cigarette smoking, chronic increase in intra-abdominal pressure, spinal cord injury, and connective tissue disorder. What are the symptoms? Feeling of something coming out of vagina, there is increased pressure, and decubitus ulcer on the prolapsed part. It is due to venous congestion mainly. What are the different managements? Packing with acreflavin, that is an antiseptic, and glycerin, this is hygroscopic. What are the different managements of prolapse? So coming to management of vaginal prolapse, it is not dependent on age or parity. So anterior colporrhaphy can be done in cystocele and urethrocoele, whereas enterocoele, some outdated methods are there. These are Moskowitz repair and Halban repair and McCall caldoplasty, and posterior colpo perineorrhaphy. Posterior colpoperineorrhaphy can be done in rectocele and laxed perineum. And what is the management of uterine prolapse? Till now we have seen about vaginal prolapse management, and now the uterine prolapse management. There is surgical management and conservative. Surgical is best management, and it is permanent. It is done in secondary and tertiary prolapse. It depends on age and parity of the patient. Coming to conservative management, there is Kegel's exercise, where these are called perineal exercise. It prevents prolapse. Progression of the prolapse is also prevented, and is done in primary prolapse only, and is advised to all pregnant women during and after pregnancy. And we could also use a pessary. Pessaries are nothing but a space occupying devices. The principle here is it does not allow the uterus to prolapse, it expands the uterine cavity. So there are different types of pessaries, such as gel horn pessaries and donut pessary, resembling the shape of a donut. And mainly the disadvantages, it is not a permanent cure. It should be changed every month. And the management, it helps to management uterocervical prolapse and cystocele only. Indications are prolapse in a pregnant female only, in that too in postpartum period. It is contraindicated to surgery or if patient refuses surgery.